Welcome to session 8 of day 2 of RIO 2025, where the focus now is future directions in leadless cardiac rhythm management. This is a presentation and discussion session, so we're really delighted to welcome our presenter Vivek Reddy from New York. Before we hand over to Vivek, let's meet our panel for this session. We're delighted to be joined by our boss, the RIO course director Devi Nair from Jonesboro, Arkansas, and Mikhael El-Chami from Atlanta. But now it's over to Vivek.
So much, Richard. Thanks so much. I'll go ahead and get started. Hopefully you can hear me okay. So my choice is to discuss future directions in leadless cardiac management. So let me move my box here. I have a number of disclosures that you'll see here, and I'll be talking about a number of investigational devices here. So I want to cover a couple of different areas. First, I want to talk a little bit about, obviously, dual-chamber leadless pacing, including a novel single device for both atrial and ventricular pacing and sensing. I want to talk a little bit about some new ideas in terms of energy harvesting, which are not that far off in the future. Avoiding cardiomyopathy is certainly something that we're thinking about when we think about leadless pacing. I want to discuss the WISE-CRT system, which has regulatory approval in many countries, as well as leadless conduction system pacing strategies. And then I'll just make a couple of comments on some other leadless strategies. So let's start with dual-chamber leadless pacers. Now, these are available. I think the audience has experience with this. And I just want to focus on one issue. Now, all of you are aware of the Reddy system, which has two components, and one in the atrium, one in the ventricle. There have been a number of publications regarding this device, and I just want to focus on the battery longevity issue, because this is a really important issue that affects every aspect of leadless pacing and affects what we're able to do with these devices. This is a publication from the IDE trial, the original IDE. And what we saw was that when you look at atrial and ventricular longevity, you can see about 5 years for the atrium, 9.9 years for the ventricle. And there are a couple of different things that one can do to modulate this, including playing with the eye-to-eye setting, changing the base rate, et cetera. More recently, of course, we have a slightly bigger atrial battery that allows a little bit greater battery longevity. And we also have the potential to program the devices with AAI with VVI backup for those patients that don't have AV conduction disturbances. So that certainly does prolong the battery longevity, because you're basically telling these two devices to work independently without beat-to-beat communication, which eats up battery. These are strategies that work. What's the future? Well, I think one of the futures may be this, which is energy harvesting. And I'm sorry, before I get to energy harvesting, this is a device that's a single device. And the idea is, instead of putting one in the atrium, one in the ventricle, put the device so that it's right here at the triangular cope, where you're able to sense atrial activity and pace atrium near field, and then have a helix that extends into the interventricular septum, so you can pace in the ventricle and sense in the ventricle. There's some preclinical work that's been done. This has not yet treated patients. There are a couple of posters that were presented over the years. This was an early version of the system with the externalized wires, showing that using this strategy compared to the intrinsic QRS, you can see when you pace the atrium on the far right, or when you're pacing the ventricle in the middle. And this particular approach, you can see that there were good pacing and sensing all the way out to almost 1 year. This technology is going to be studied in patients. This is in a human, in a cadaver human explanted sort of model, and you can see where the device is hooked in. And in this particular case, I think this is actually a simulation here. So I think that this is a really exciting approach, and this is a technology that should go into clinical trials, hopefully in a year or so. There's also the concept of energy harvesting, that is creating energy so that you don't need to worry about battery issues. So this autonomous leadless pacemaker system is self-powering, and the idea is to eliminate these concerns about end-of-life management and battery constraints. So this is what the device itself looks like, as well as the various components, including the programmer and the monitor. And the idea is to have, well, really not infinite, but near infinite amount of energy. And I'll show you how that works. It converts mechanical motion, the kinetic energy, into electrical energy that can be stored and used. It'll enable other capabilities like continuous monitoring, for example, and as well as adaptation. This will start off as a ventricular device, but eventually a dual chamber is the plan. So how does it work? Well, there's an element inside that vibrates with the motion of the heart. And so this energy is created, it's harvested, and it's converted. And so it's able to basically act as an autonomous pacing system. This is the device itself. You see the implant there. You can also see the delivery catheter is deflectable, as these delivery catheters typically are. And then here's just a preclinical study navigating the apex in a sheep model, affixing it, and then once it's released, there's a tug test. Again, this will hopefully start clinical trials, hopefully sometime next year. There's another strategy of energy harvesting, it's the electrochemical strategy. Now, this is further off, but still an interesting one. The idea here is, as by way of background, we know that if you look across biological membranes, you have ion-based charge transfer, and it is possible to take advantage of these transient differences in ion concentration. And so the idea would be to have electrodes, one that's in the interstitial space, one, for example, in the blood pool, and as the cells are going through their activation, you'll end up seeing a potential difference here. And there's the possibility to harvest this energy, to take these small amounts of energy that are there, put them together and use it to pace the next cycle, for example. There was a abstract at HRS this year, as well as a manuscript that was published in Heart Rhythm by these investigators, and they basically studied this. These are plunge electrodes, and the idea was to plunge them. This is an open surgical model. And what they did was they said, okay, let's use these plunge electrodes and see how much energy can actually be harvested. I mean, is this even possible? And they were able to harvest about 25 nanojoules of energy for each heartbeat. Okay, and that, by the way, they estimate is only 7% of the available tissue energy. So there may be ways to get even more energy. But ultimately, their idea is to have a chipset that has 8 needles, each harvesting 25 nanojoules. So 8 times 25 would be 200 nanojoules per heartbeat. And from their perspective, that's sufficient, because if you had this, now there'll be some inefficiency, some energy used for pacing, some for the actual electronics, and some excess energy that would be stored in an energy bank. So the idea would be to have a way to power this continuously. Again, this is an early stage, and the device is still in development. Okay, let's move on to talk about avoiding cardiomyopathy. This is an obvious issue when you think about leadless pacing. I want to point out one manuscript a couple years ago. It's notable for looking at over 300 patients who had normal ejection fraction, and you can see over 40% RV pacing burden. And what was interesting is, basically, they saw tachycardia-induced cardiomyopathy, pacing-induced cardiomyopathy in about 8% of patients. It was also interesting that there was less myopathy when there was a high septal location versus an apical septal location. So I thought that was interesting. But I think this 8% is certainly something we want to avoid. And frankly, it probably is the tip of the iceberg. There's probably another 15 to 20% of patients who don't do as well, but may not have as low a drop in ejection fraction. So how can we mitigate this issue? Well, all of you, I believe, are aware of the WISE-CRT system. This is a system that basically works in concert with an existing device, pacemaker, defibrillator, etc. The system itself has a transmitter that's subcutaneous between the ribs, connected to a battery that you see here. And then separately, either retrograde or transeptal, you implant this electrode. It's a very small electrode that's placed into the left ventricle itself. You can see the size of this. It's very small, and it rapidly endothelializes, both because of its size and the polyester jacket of the device. There have been a number of studies, including the first WISE-CRT, first in human experience, and the Select LV, which we're involved with, as well as the registry and then the pivotal Solve CRT trial. I'm not going to go through all the data. Suffice it to say that in Solve CRT, which ended up being a single arm trial, patients did do well. These patients who failed conventional CRT, with this technology, they had a reduction in end systolic volume, and their safety endpoint was met. So how could this help us? Well, we had a couple of patients who had chronic AFib. We put a leadless pacemaker in them, and a couple of them developed LV dysfunction, as you sort of expect in some small percent of patients. And so the strategy that we used in these patients was to use the existing RV leadless pacer as the co-implant and put in the WISE-CRT system, as you see here. There you see the RV pacemaker. There you see the electrode in the LV. That's the pacing pellet. And when we put this together, you can see that the QRS narrowed in this patient. And so this is a case report of 2 patients showing improvement in ejection fraction and reduction in ventricular volumes. Later, there was a larger case report, 8 patients, again, same idea, improved ejection fraction and improvement in LV dimension. So this is a concept that's being studied prospectively in the so-called TLC trial. There's a single-arm study of leadless pacing plus the WISE-CRT co-implant, and that's ongoing. There's also the idea of using the WISE-CRT with a pellet placed directly to pace the left bundle area. So there's some preclinical work that was done, and then there was a clinical series that was published of 8 patients, and you can see there the co-implant that's placed directly at the left bundle area, and here you can see on the left side is just the left bundle, and on the right you see the narrow QRS from the left bundle area pacing with the LV activation time of 88 milliseconds. So this is also being studied in the so-called ACCESS CRT study, also a single-arm trial of left bundle area pacing with the WISE-CRT system. And then let's talk about leadless conduction system pacing, a fully enclosed system to directly pace the conduction system. So this is a technology that we and Devi and Shefo Doshi and Pierre Nuzzo, we worked on. And the idea is to place the leadless pacemaker. It's a modified device, as you can see, with its extended helix. And the idea is to basically burrow it through the interventricular septum from the right ventricle so as to pace the left bundle area. And there's an introducer and a delivery catheter, which are both actually undergoing evolution. But we did a so-called pass-pull study with this technology. And I'll just show you that. And there's also some preclinical data that was presented at HRS last year showing that this technology, you have good pacing and sensing out to 12 weeks. Before treating patients, we did this ex vivo human heart study where we had a explanted heart cadaver set up, and we could sort of prove to ourselves that we had a reasonable chance of putting it in the right location. And then we did this pass-pull study. The idea here was in patients who were planned for leadless pacing to try to put this in position, get the values, and then take it out and give a conventional device. So this is not a very large study. 14 patients are enrolled, of which 12 actually underwent the implant. In 2, it wasn't deployed because we couldn't achieve an adequate enough position because of the delivery sheath. So ultimately, we were able to implant successfully in 10 patients. If you look at the freedom from adverse events, there were 2 adverse events in these 14 subjects. One was a patient with worsened tricuspid regurgitation because of interaction with this with the device, with the tricuspid valve. And so we certainly learned from that. And there was another patient that had a hematoma and from the internal jugular because all these procedures were done from above. In terms of performance, we were able to evaluate the tether mode on 10 patients, reasonable pacing and sensing. Procedure times, frankly, that were a bit on the long side, and fluoroscopy times a little bit on the long side, but sort of expected for this first in human experience. We had in half these patients, we had left bundle area pacing, and then in 3, it was just deep septo, and in 2, it was simply RV pacing. So, and then here's just one example of a patient, and you can actually see on intracardiac ultrasound, you can see the tip of the distal electrode in this particular patient. So this set the stage. The technology has undergone some evolution, importantly, particularly in the delivery tool, which has gotten substantially better. So we actually hope to do the first fully, chronic implants, hopefully before the end of this year or certainly early next year. With that, I'm just about done. I just want to point just two quick points. There are other temporary pacing strategies being studied. One is this parasternal strategy, and the idea is to use this technology to make an incision right next to the sternum and advance a lead that sits directly on the epicardial surface, on the extrapericardial surface, actually, but even then can pace and sense. This could be used temporarily, or it could be used even permanently with a leadless device that's placed underneath the skin. The other is, I just want to bring up this concept of bioresorbable pacemakers. Very interesting concept. I mean, it didn't even occur to me that this was possible, but apparently it is possible to actually create these pacemaker technologies that are completely bioresorbable. They're very small, as you can see in that top right image. And in this Nature article, they show that this could be placed in a canine model to show they could do pacing. And because they're so small, you could actually have multiple, even do multi-site pacing. Again, this is very early stage work. There's still a number of questions in terms of who would you want to use a bioresorbable technology versus permanent, et cetera. With that, I think I'm going to go ahead and stop. Thank you.
Great. That's a wonderful overview, Vivek. Maybe I can ask you, before I open this up to the rest of the panel, the patient selection. You've talked about the concerns for battery life. I mean, their battery lives are very good, but obviously once you've delivered it and it's been in for 10 to 12 years, then your options are beginning to get limited. So who are the patients that we should be using this type of technology for?
Yeah, look, it's a tricky one, right? There are advantages, you could say, in older patients. They may only need one device for the rest of their life, and there's some advantages there. For younger patients, do you want them to have leads for the rest of their life? So honestly, I think you can come up with reasons to use it in any patient. I think the bigger questions are those related to LV dysfunction. Which are the patients that are, one problem we have right now, as you're well aware, we do not have a good way of predicting which patients are going to develop LV dysfunction. If we did, it'd be an easy decision. Maybe the 70% of patients that have no diminution of function, you could use a leadless, and the remaining you would not want to, at least currently. Of course, as we talked about, there are new devices that might be useful in those patients also. So I guess I'm really avoiding your question. I think that the fact is, we tend to like leadless pacing quite a bit at our center. We use them fairly liberally, frankly. And I should also note that we're comforted by the fact that it seems like it's pretty easy to take these out even many years after. So because of that and the ability to, replace, at this point, despite the potential limitations, we still have been pretty liberal about using them.
So maybe I can ask a similar question, Dr. El-Chami. Maybe you can tell us about your experience and also how much cost of these devices influences your prescribing practice.
Yeah, so first, thank you, Vivek, for a comprehensive presentation. Thanks for inviting me. So in terms of thinking about life cycle management, as Dr. Reddy mentioned, most of these patients really need one or two. My thinking about the approach is, if you don't have cardiomyopathy and you need a pacemaker, you have low burden of pacing, or if you're like 80-year-old, I think leadless pacing is the best device for you because of all the potential benefits. And most of these patients require one device. Even though I've extracted a lot of these devices, I think for those patients, you can abandon the device and place a second one down the road. And now my thinking about this changed a little bit with the atrial device, because as you know, the right atrium and the right atrial appendage might not possibly fit more than one, maybe it fit two, but I think we have to think about extractability more now with the presence of a right atrial device or a dual chamber system. Even we published our experience to minimize the hardware in the heart, and in patients with isolated sinus node dysfunction, we most of the time just implant an atrial leadless. And among 40 or 50 patients that we've done so, we had to go back and upgrade one of them. So that's one way to minimize battery, even though battery, or to maximize battery longevity, even though now we have the AAI, VVI backup pacing. And one way also to potentially reduce complications, because you don't have to put a device in each chamber. In terms of cost, to be honest, maybe that doesn't factor a lot in the US, maybe it should, but I think my thinking about reducing infection, reducing complications, the cost-benefit ratio might be acceptable with those devices.
Well, obviously, I practice in the developing world in the United Kingdom, so cost is always a factor. Devi, can you tell us, I mean, I'm intrigued about the concept of leadless septal pacing, because for me, conduction system pacing is my get-out-of-jail-free card if I can't get an LV lead in. Can you talk about your experience of that and how far we are off from that being mainstream and a practical possibility of getting a leadless device to pace the left bundle?
Well, Richard, as Vivek said, we're still quite away from, maybe a few months away from doing the first chronic implants. And I think, it's so early, and I think the fact that we were able to show that it's feasible is a first step for me. But still, as Vivek said, the implants are done through the IJ, which is not how most leadless implants are done around the world. It's a transfemoral approach. So that's one thing. There's still work that has to be done on optimizing delivery, optimizing pre-mapping. Of course, the system that was used is a system that could do pre-mapping. So maybe we could target a good location, just like we would with transvenous leads. But there is still issues with the size of the device, because as Vivek said, even for a regular leadless pacing, high septal is better. But we know for a fact that to get the main bundle, you have to be higher up in the septum, and the devices are, if they are too long, they will affect the tricuspid apparatus. So I think those are all things that we have to kind of think about just from a mechanics, implant, a strategy. All that stuff has to be worked out before it becomes a therapy that everybody starts using. But to me, I think it's something to look forward to. There's at least a couple options that are coming up. And the idea of having just a total leadless system, even with the WISE-CRT, is something that I've been using quite a bit now.
Wonderful. So I'm going to go back to Dr. El-Chami and put you on the spot a little bit, because you have just presented to your local emergency room with heart block. You're the person you are now, of your young age and good physical state. What device would you ask them to implant into you?
Well, first, thank you for calling me young and in good physical age. I don't know if I qualify for that, but thanks. I think, someone like me, if I'm going to be 100%, if I have complete heart block, maybe I will choose conduction system pacing, because I'm 49-year-old and I expect to RV pace 100%. But if I've had intermittent pauses or very low need of pacing, or even maybe severe cardioinhibitory vasovagal syncope, and it's not my first episode, then I think leadless pacing is very reasonable. Put a leadless pacer in me and program it VVI 40 or 50, and I hope that will last me, 15 years or so, maybe even more.
I mean, let me reassure you, Mikhael, anyone younger than me is young. So Vivek, let me come on to you. So I'm really intrigued by self-charging or self-perpetuating devices. But I guess the question that many people may ask is, how far away from them are we, and how much can we trust them not to just drain the battery and fail on us without much warning? Where do you think the future is on those devices?
Yeah, I mean, so I talked about a couple of different possibilities. The one with the piezoelectric transducer, that based on kinetic energy being transferred to converted to electrical energy, that's imminent. I mean, the preclinical work is being done right now. First in human is likely going to happen sometime early next year, Q1 or Q2 of next year. So that's imminent. Now, to the question of, well, will they work? Fundamentally, the preclinical data suggests yes, but of course you get into patients, and I'm not worried about let's say the normal LV or the normal RV function patients, but you wonder about patients who develop ischemia, who have dysfunction, who have other issues where maybe the motion isn't quite the same. Will you start having issues with battery drainage and inability to keep up, so to speak? So those are the questions I think we need to understand. Even if the answer to that is yes, by the way, as you're well aware, there's a large population of patients that would still benefit with normal function. So I think your points are well taken. Obviously, as I say, the proof's in the pudding, so we'll have to see what the data looks like, but I'm pretty optimistic about them.
And Devi, let me ask you the final question. How important is leadless in the atrium, and how much is that going to change the way that we pace and practice?
It's a great question, Richard. I don't think 2 years ago I thought I would be doing single chamber atrial pacing or AI pacing. And today that's almost standard of care in my lab for 600 syndrome. For once, we actually can say that we are keeping up with Europe and doing AI pacing. So to me, I think that, the idea that you could do just a single chamber pacing, and to me, that's physiologic pacing. If I can, we're talking about physiologic pacing with CSP. So to be able to do AI only pacing and only upgrade if you need. And, we have actually done in patients that we worried about maybe heart block, we'll actually do ILR, long-term ILR monitoring in these patients. And if they have any kind of heart block, then add on the VVI device. So having that modular, therapy is very, very useful. Having the option of doing an AI VVI backup, as Vivek said, that conserves battery. So there's a lot of things coming in. I think even the battery longevities for both atrial devices changing. Currently, I think most recently there was an AR2 device that was just released in the US, and it seems to have a little bit longer battery longevity. So I think the therapy is only going to get better, hopefully, right? So I think a large majority of my 600 syndrome patients now just have atrial-only device.
Brilliant. I mean, I love the idea that, because at the moment, a lot of the time we put in dual chamber devices because we're worried about AV block, even though the primary problem is sinus node. And so the idea of a modular system that you can change easily and upgrade if needed later on is pretty cool. Look, that's all we have time for in this session, but I'd really like to thank Vivek, Devi, and Mikhael for a fascinating 30 minutes. There's still much more to come in the Day 2 program. Devi's in it for the long haul. She's going to be doing a case in just a minute. So come back soon.
Thank you.